Sanft from Yale Cancer Center.
Thank you so much. I'm going to be the last presenter of the session. I know that we have, I think, 2 of our poster people in the audience. I invite you to come up to the tables here for the question and answer period. So come on up now and we'll have questions at the end. And I think we have at least 2 virtually, Dr. Kogan and Dr. Bond. So I'd like to thank the conference planners for inviting me today. My name is Sanft. I'm living in Connecticut and really honored to be here. I have 4 abstracts to talk about today, but I thought I would just tip my hat to Dr. Gans, who's one of the mothers of cancer survivorship and published this article, The 3 Ps, palliation of long-term and late effects, prevention of future cancers, and promotion of health to maximize well-being. Survivorship care, for those of you who are working in this sphere, you know, traditionally is boxed in at this time after treatment ends. But even back in 2011, a decade ago now, Dr. Gans calls out that the definition of survivorship really starts at diagnosis. And so I think we're evolving now in order to be as inclusive as possible. And, you know, I love that she wrote in here that we must design therapies at the outset to not only maximize cure, but to minimize long-term side effects and other more serious effects of cancer treatments. My 4 abstracts that I'll be presenting today may seem somewhat unrelated at the outset, but really they're all trying to better predict the patient experience based on who the individual is walking into our clinic and then what happens to her when she's undergoing treatment. I'll start with Dr. Henry's and colleagues' abstract from the University of Michigan, looking at risk factors for long-term adjuvant chemotherapy toxicity using pre-treatment host factors and self-rated treatment symptom bother. So chemotherapy-induced peripheral neuropathy occurs in about 40% of patients, although the range is quite broad in the literature. And hot flashes, there's less about the impact of chemo directly on hot flashes, lots more in the adjuvant setting on hormone therapy, but I did see that up to 40% of pre- and perimenopausal women will develop hot flashes immediately after chemotherapy. In this study, the investigators looked at the population of patients undergoing clinical trial randomization in NSABP B30. This was a randomized controlled trial looking at 3 different types of adjuvant chemotherapy in lymph node positive early breast cancer patients. They wanted to understand the predictors of neuropathy and hot flashes in 2 different time points. The acute setting was defined as the first 12 months, and the subacute setting was defined as up to 2 years or 24 months. They did also ask about baseline symptom bother. This is a question from the Fact General that I'll show you in a second. And then they also calculated the toxicity index, which is a sophisticated equation that takes into account all toxicities at their grade and their frequency over time. This is just what the symptom bother, that GP5, is asking. So 2 broad categories of findings, the chemotherapy-induced neuropathy and then the hot flashes. In the analysis looking at the neuropathy, you can see here the acute period with the factors that are significantly associated, circled in red. I know there's a lot of them. And then in the subacute period, the factors that are associated, circled in red. Now you can see here that across the lines, baseline numbness, baseline symptom bother, higher weight remain significant in both time periods. However, in the acute period, race was a factor and not in the subacute period. And then in the later subacute period, age and history of mastectomy became associated. Similar appearance, but this is talking about the hot flashes. And you can see here that treatment, hot flashes at baseline, they stayed the same over both time periods, and age as well. And as in the acute setting, weight was an issue that did not stay significant in the later periods, whereas the addition of hormonal therapy, not surprisingly, emerged as a factor in the subacute period. So what are the key takeaways from this abstract? It is possible to separate predictors of developing symptoms after chemotherapy acutely in the first 12 months and then persisting. And what predicts each phase is not necessarily the same. So to me, I think what this can do is help us counsel patients more specifically on what to expect based on their baseline factors. Now, there were a lot of studies to choose from, and I must have made like 3 different versions of this table here. There's a lot of information in the literature about chemotherapy-induced peripheral neuropathy. What I tried to focus on here, you can see Dr. Henry's study at the top, were other people who had listed different predictors of neuropathy. And I did add in this one study that I could find that looked at predictors of hot flashes after chemotherapy. Certain things stayed the same in across all of these studies. So we need to be cognizant of patients with pre-existing neuropathy, pre-existing hot flashes, and those who are bothered by side effects early after diagnosis. So this study, to me, adds nuances to the predictors of side effects at different time points. Some curiosities, that GP5 question, bothered by side effects, was asked at baseline. So these patients presumably had only undergone surgery so far, I believe. So what is that telling us about that group who are bothered so early in the course? And also I'm curious why those with mastectomy would be more likely to have neuropathy. And I'm not gonna speculate here because I have 3 more abstracts to go to, but be curious to hear from our scientists. The second abstract is by Dr. Kogan and colleagues from Columbia, looking at new and persistent sedative hypnotic use after adjuvant chemotherapy for breast cancer. So benzodiazepines like lorazepam and Z drugs like zolpidem are commonly used to treat chemotherapy-induced nausea, anxiety, and insomnia. Probably the greatest use of this is for insomnia. That's their general population indication. And insomnia, I'm sure those of you who treat breast cancer patients, this resonates with you. It's 3 times higher in cancer patients, and it persists in over half of breast cancer survivors at 4 years. These investigators looked at the IBM Market Scan claims database to capture prescription history of these sedative hypnotics and to try to characterize their use over time. So if you focus on the top graph here, what they did was they looked in all breast cancer patients who are undergoing chemotherapy in their database, and they looked back over the past year. Anyone without a prescription for a sedative hypnotic was considered naive, prescription naive. That was period 1. In period 2, they analyzed anyone who filled a prescription for a benzo or a Z drug. And then in period 3, they looked at patients who filled at least 2 additional prescriptions. And if this was positive across the time period, you became a new persistent user. In the bottom part of the screen here, you will see that this is the total population of patients who they were looking at in the benzodiazepine cohort, 17,000 patients total. Of this group, 4,000 filled prescriptions for benzodiazepines during chemotherapy. That's 25% of this entire cohort. And that's about 10% of the entire analyzed population filled a prescription for Z drugs during chemotherapy. And then when they looked for this second behavior here, you can see that about 27% of patients filled additional prescriptions for benzodiazepines, and an additional 33% of patients filled additional prescriptions for Z drugs. And I believe in the written abstract that only 110 patients or something refilled both or were on both. So, but maybe we can talk about that. When they looked at the logistic regression models, they found that patients who were older, who were on Medicaid, or who had short course chemotherapy were more likely to become new and persistent users of benzodiazepines here, and the short course chemo more likely to become persistent users of Z drugs. The key takeaways from this abstract is that a sizable number of women receiving adjuvant chemotherapy become new users of sedative hypnotic medications, continuing to fill prescriptions up to 1 year. And this may represent a preventable complication in the management of early stage breast cancer. So there isn't a lot in the literature as it relates to this type of prescriptions behavior in breast cancer patients. I did find a study looking at 200 patients undergoing chemotherapy for breast cancer, and they used daily sleep aid use logs throughout the course of the year. And the information is presented a little bit differently. Overall, in the actual article, about 20% of the population was using sleep aids, but these were diaries over the course of the year. But you can see here that when people use sleep aids during chemotherapy, this also confirms that they were mostly prescription sedative hypnotics, although this study captured all the over-the-counter remedies as well. And that even up to a year, the usage was less, but still rather high. So this study highlights the need for caution and conversation when prescribing sedative hypnotic medications. And I think in general, we need better access to things like CBT for insomnia, which is the gold standard treatment. Maybe we need to start focusing on these highest risk populations. And one thing to just remind you all that I had to be reminded of, that in the older patients, there are significant adverse events in the use of these drugs. So 5-fold increase of cognitive adverse events, and over 2.5-time risk of things like falls and hip fractures. These are not to be used without caution. One curiosity is, why would short course chemotherapy be associated with increased use of these medications? Okay, our last two abstracts are separate but related. The first one is with Dr. Bond and colleagues looking at work status changes and associated factors in a sample of Norwegian long-term breast cancer survivors. About 60% of breast cancer survivors are diagnosed within working age. And the experience of patients who are diagnosed and the impact on their work is growing in the literature. We do know that it's very important for quality of life and financial stability of the family for patients to continue to work if they want to. This study looked at about 2,000 breast cancer survivors 8 years from diagnosis, so a long period since diagnosis, and stratified the results of their survey into reduced work status versus maintained work status. So let me walk you through the findings here. Again, at diagnosis, the 87% of the patients surveyed reported that they were working. And at 8 years, this dropped to 56%, which is 63% of this total population who maintained work. 37% reduced their work, and when they looked at the reasons for this, you can see that most of it was drawing a disability pension. When asked about the reasons for reduced work, 64% reported late effects as a main or partial reason. And for those women here who went on to disability, 83% said breast cancer was the main reason. When they did multivariate analysis, they found that chemotherapy, cognitive function, and fatigue were significantly related to not returning to work or reduced work status. So the key takeaways of this abstract are the majority of breast cancer survivors who were working at diagnosis remained in paid work 8 years later. The proportion collecting disability increased by a factor of 4. Chemotherapy, reduced cognitive function, and fatigue were associated with reduced work status. This is one of the longest, longer-term analysis that I could find, but there's a good literature to suggest also that severity of disease, chemotherapy, and side effects or perceptions of side effects slows return to work, both at 2 years and at 4 years. So this confirms certain factors influence work after cancer. Still, in some curiosity, 34% in the reduced work group did not report late effects as a reason, so there is some speculation that reprioritization may play a role in what happens to women after diagnosis. I'm not sure if that's what's going on there. Certainly, interventions are needed to minimize treatment-related effects, and I meant to add that there is a randomized trial out of, I believe, the Netherlands called iWork, looking at cognitive rehab in order to try to improve the return to work or the work experience in cancer patients. Our last abstract is by Dr. Emerson and colleagues from UNC, Consequent Job Loss, Return to Work, and Multidimensional Well-Being After Breast Cancer Treatment in Working-Age Black and White Women. Most studies looking at work experience after diagnosis are in white breast cancer survivors. These investigators tracked 1,600 breast cancer survivors in North Carolina who were working at diagnosis. About half of them were Black and half were white. They measured well-being, including the disabilities of arm, shoulder, hand, and the FACT surveys. And then they categorized work status as sustained, return to work, consequent job loss, and persistent non-employment. And they have some beautiful graphs here that I'm happy to share with you. Look, again, 84% of the population sustained work, similar to the abstract that we saw before, but about 16% had subsequent job loss, okay? And then here in the baseline not working group, you can see here this blue line where the return to works, and the orange was persistent non-employment. Now, when you look at the multidimensional well-being, that's the FACT survey, you can see here that the sustained work and return to work scores were much higher than those in the red stars, which was the consequent job loss. When they looked at the analysis by race, they found that those who experienced job loss were much more likely. That was happening in the Black part of their cohort, and that they had also greater disabilities of their arms and shoulders, and that that population was more likely to work in craft, factory work, service work, or labor. So the key takeaways are that sustained work and return to work experiences higher well-being in all domains. Job loss is more common in Black women compared to white women in this cohort, and that Black women with job loss reported worse well-being, greater disability, and work-related difficulties. There is a nice systematic review of 26 studies that I would like to highlight here. And again, return to work or the work experience was impacted by the severity of cancer, chemotherapy, adverse events, and other factors that are related to the individual. Only 3 of the 26 studies reviewed here had race listed as any part of the findings in return to work. And 2 out of these 3 are the same population. One's a qualitative, one's a quantitative study. And I just listed the 2 here that low-income Latinas did not reach return to work levels compared to high-income patients. And another study by Booknight in the JCO in 2006 also showed that if Black patients were less likely to return to work. And within that same study, perceived employer accommodation, or the lack of, or discrimination were independent predictors of return to work. So, I think it's time to start asking more about the work experience in our patients. It may be useful as a screening for a wide range of well-being, particularly in people who are working at baseline and then experience job loss. We need to start advocating for additional interventions. And what is the role of the employer? I think there's a growing amount of interest in this, and I know that Johns Hopkins, for instance, has developed an employer tool that can be run by nurse navigators and can help not only the patients having cancer who are employed, their loved ones, but also their managers and colleagues. So what can we take away from today? Patients presenting at diagnosis will have differing experiences based on who they are as individuals. And, can we start to identify those at highest risk for complications and begin tailoring treatment? Can we minimize prescription sedatives, especially in older patients? Can we minimize fatigue and cognitive effects so women can continue to work if they wish? And can we support our patients better with fewer side effects and better employer support to minimize job loss? Ultimately, we want to make that box as big as possible to include everyone so that survivorship starts at diagnosis and really is just thought of as the patient experience. Thank you so much.
Thank you, Dr. Sanft, and thank you to the presenters of this excellent work. I know we're at the top of our time, but we could take a couple of questions if anyone wants to come to the microphone or submit online. Otherwise, maybe everyone is needing to finish. Dr. Sanft, did you want to ask any of your presenters any questions? Or?
Well, there were lots of speculative questions within each of the abstracts, and I don't know if either anybody here or online wanted to ponder some of the curiosities that I mentioned. Just put it out there.
I'll say one quick thing. So I'm Dr. Henry. I'm the one who did the first abstract. And one of the questions is about this GP5, which is a question that gets routinely asked with a lot of patient-reported outcomes studies, and it's actually been a pretty hot topic lately. Folks in ECOG Akron in particular, but also across all the cooperative groups, have been very interested in including and analyzing this particular question. And so, especially in a study like ours, where patients had undergone surgery but hadn't undergone any systemic therapy yet, really one question is, what are patients thinking of when they ask that question? And so one of the things we thought of is they could be talking just about the side effects of surgery. I think one of the other things, though, is, are people sort of projecting ahead and worried about the side effects of chemotherapy, worried about the effects of things to come, and answering it sort of from that perspective. And so I think it's always very important when we're asking patients questions that we're very clear in how we want them to answer it so that we can interpret the findings. Patient-reported outcomes are critical, but it's important for us to be able to actually use the data and not just have it sort of be wasted effort on the part of our patients, because we really can learn so much from our patients.
Thank you. We have a question at the microphone.
Hi, Lindsay Livingston again. Is there a correlation between metabolic factors and the frequency of hot flashes? I suffer from hot flashes.
Dr. Henry?
I mean, there are definitely a lot of different factors that go into whether or not a patient has hot flashes. Part of that is definitely ovarian function. Part of it is genetics. Part of it is weight or obesity. I think the important thing to remember with hot flashes is that while estrogen is one of the best treatments for hot flashes, most of the time we are dealing with a patient population that cannot take estrogen, and there are treatments out there that are effective for most but not all patients. So things like low doses of SSRI, antidepressant medications, things like gabapentin. Other things are being studied. Acupuncture is being studied, hypnosis is being studied. So hopefully you have had the opportunity to try those things. Hopefully everyone has who is suffering from hot flashes, because they can be incredibly disruptive. And with some of the things that we look at that chemotherapy causes, some of them are definitely modifiable or treatable, and we want to make sure that people are able to take advantage of that.
Thank you so much.
I have one last question for Dr. Kogan, who's joining us virtually. Do you have thoughts about why the shorter course chemotherapy was associated with more sedative use? I assume that's mostly docetaxel cyclophosphamide?
Yeah, this is a challenging one for us to explain, and Dr. Sanft and I kind of went back and forth a little bit about it. A theory was that maybe that chemotherapy regimen has more steroids or is more intense, although I don't know that that's the case. Another thing is that it could be sort of paradoxically that an earlier stage cancer with a shorter course of treatment is for some reason more anxiety provoking for the patient. And for that reason, we're seeing people who, afterwards are worried about recurrence, sort of living with the survivorship, and who, maybe have significant mental health symptoms that are being managed with a sedative hypnotic prescription that they picked up for another indication during the chemotherapy that was meant to be temporary, but that is treating other symptoms that maybe could better be managed another way, because this could sort of be seen as a complication to treatment if that medication is not actually indicated for something.
Interesting. We have another question at the microphone.
Thank you. Sorry, I realized I forgot to introduce myself earlier. My name is Dr. Ellie Prusaloglu. I'm an OBGYN resident at Brown, and I'll be heading to Yale next year as surgical oncology fellow. My question was for the author who assessed return to work in the Black and white populations. I may have missed this, but was there any assessment of either FMLA coverage, insurance type, or any other specific discrepancies between the two racial populations that could account for some of the findings?
Yeah, so that's a great question. We preliminarily looked at this kind of as a mediator, and the question being asked from whether or not they had insurance and insurance type. And so this is something that we're, I think, thinking about as we're thinking through this. Overall, the goal of thinking how, systemically, how broadly we can look at these different issues that can affect this during time of treatment and then into long-term survivorship. So that's kind of the next step, right? That's something we're looking at. But I will say in the preliminary investigations, these things were important in how we're constructing, how we thought about something like having the privilege of having a partner who you may be able to look at their employer-based insurance versus single women and during that time of treatment and beyond. So these are things that are currently under investigation. So,
that's awesome.
Thank you.
I'll mention you might want to think about including financial toxicity assessment and the pre and the post intervention if you do any additional assessments, because even if patients are well insured, if they're coming into their cancer treatment with higher financial burden, that might also influence your findings. But
Yeah, thank you.
you.
That's a great suggestion.
Thank you so much to the presenters of all of this very interesting and, I think, thought-provoking work. Thanks to our excellent discussants, and also thanks to those who were willing to participate virtually, sometimes from the middle of the night. We really appreciate all of your participation, and hope everyone has a great rest of the meeting. Take care.